respected teachers, fellow colleagues, and learned audience. Welcome to you all. Today's ECG lecture number 61, topics cardiac chamber enlargement. Detection of cardiac chamber enlargement. Introduction. Cardiac chamber hypertrophy and or enlargement has important prognostic implications. ECG is the technique most often recommended in the diagnosis of chamber enlargement. The two terms, enlargement and hypertrophy. The enlargement term is used for atrium. The hypertrophy is the term mainly used for ventricles. There are 4 chambers in the heart, 2 atria and 2 ventricles. So each chamber can be enlarged by disease conditions. The right atrial enlargement, left atrial enlargement, right ventricular hypertrophy, and left ventricular hypertrophy. Atria become dilated rather than hypertrophied. Dilatation of heart chambers in which heart muscles are stressed and chamber become enlarged. Morphologies of ventricular enlargement are secondary to a hypertrophy rather than to dilatation. Hypertrophy in which the heart muscle fibers actually increase in size with resultant enlargement of chamber. The two terms, hypertrophy and enlargement, are often used interchangeably. So enlargement versus hypertrophy. Enlargement is simply the increased chamber size, and hypertrophy is simply increased chamber wall thickness. This is the structure of the heart, the reference from Robin's pathology book. The upper left shows the concentric hypertrophy of the LV without dilatation. The next, concentric hypertrophy of the LV without dilatation. Now this is the hypertrophy of the LV with dilatation. This is the normal structure of cardiac muscles, and this is the hypertrophied muscles. So, ischemic presentation of the causes and consequences of cardiac hypertrophy. The cardiac hypertrophy occurs when increased mechanical work of either ventricles. It may be pressure overload, it may be volume overload, or it may be trophic signals due to activation of beta-adrenergic receptors. In case of pressure overload, the hypertrophy occurs. The new sarcomere develops, the new sarcomeres assembles in parallel to the long axis of the muscle cells. As a result of the cross-sectional area of the muscle increase and hypertrophy occur. But in case of volume overload, here the increased sarcomeres are arranged within the existing sarcomeres. As a result of sequences, it stresses and dilatation occurs. So the hypertension causes pressure overload, valvular heart disease causes pressure and or volume overload, and myocardial infarction causes regional dysfunction with volume overload. As a consequences, increased cardiac work, increased cell stretch, hypertrophy, and or dilatation. So, characterized by increased heart size and mass, protein synthesis, abnormal proteins, fibrosis, and inadequate vasculatures. And thereafter the consequences of the hypertrophy. So atrial activation occurs after impulse formation from the sinus node. Normally, activation of the right atrium occurs first, followed by left atrial activation. Abnormalities of the P wave that are related to anatomic and physiological abnormalities in the right and left atrium. The term P mitrally, P congenitally, and P pulmonary were later replaced by left atrial enlargement and right atrial enlargement. Some students frequently asked question in the examination, the causes of the right atrial enlargement. The some causes here, the congenital heart disease, especially pulmonary stenosis, pathology of Fallot's, pulmonary stenosis and regurgitation, pulmonary hypertension due to any cause, tricuspid stenosis and regurgitation, right ventricular hypertrophy due to any cause, and Everstein anomaly. Some causes of left atrial enlargement, mitral stenosis and regurgitation, left ventricular hypertrophy, aortic valve disease, cardiomyopathy. Causes of left ventricular hypertrophy. It may be due to pressure overload or due to volume overload. In case of pressure overload, systemic hypertension, coarctation of the aorta, aortic stenosis, and hypertrophic cardiomyopathy. Due to volume overload, aortic regurgitation, mitral regurgitation, patent ductus arteriosus, dilated cardiomyopathy, and VSD. Causes of right ventricular hypertrophy are more similar to the right atrial hypertrophy, the congenital heart disease, pulmonary stenosis regurgitation, tricuspid stenosis regurgitation, mitral stenosis hypertension, and ARVD. Causes of the biventricular hypertrophy, VSD, PDA, and Eisenmenger syndrome. Now, what should you look for an surface ECG? In case of atrial enlargement, look carefully the POF. And in case of ventricular hypertrophy, look carefully the QRS complexes. The amplitude of the R wave or amplitude of the S wave, QRS duration, or ventricular activation time. ECG features of left atrial enlargement. Features of left atrial enlargement. The POF is normally best observed in the limb leads, especially in the lead 2 and V1. In lead 2, it is upright, and lead V1, it is biphasic. The normal POF duration less than 120 milliseconds. So in case of left atrial enlargement, POF duration more than equal to 120 milliseconds. In case of NOST POF, with interpeak duration more than 40 milliseconds. In case of V1, lead V1, the terminal negativity in lead V1, that means P-terminal force, duration more than 40 milliseconds or depth more than 1 millimeter. Features of right atrial enlargement, tall peaked POF amplitude more than 2.5 millimeter in case of limb lead, especially lead 2, and POF amplitude in the V1 more than 1.5. In case features of biatrial enlargement, as a combination of two atrial enlargement in same ECG. Here, POF in the lead 2, amplitude increase more than 2.5 millimeter and duration more than 120 milliseconds. In case of V1, the positive portion, that means the right atrial part, is more than 1.5 millimeter, and the negative terminal force more than 1 millimeter depth and more than 40 millisecond duration. This is the normal POF. POF is composed of right atrial portion and left atrial portion. Right atrial portion is the first occur, then left atrial portion, and the dome is produced by the two atria. Here, the right atrial hypertrophy, only the right atrial portion amplitude increased more than 2.5 millimeter. And in case of left atrial enlargement, the duration more than 120 milliseconds, as the left atrial portion is increased. So this is the normal POF. This is the P pulmonary. This is the P mitrally or left atrial enlargement. So, in very easy to memorize, the right for height and left for length. So, if we observe in case of lead 2 and lead V1, in case of lead 1, the POF amplitude is more than 2.5 millimeter, then it is the right atrial enlargement. In case of V1, the positive portion is the right atrial part, and the amplitude is more than or equal to 1.5 millimeter, indicates right atrial enlargement. In case of left atrial enlargement, in lead 2, the duration more than 120 milliseconds, and in case of NOST POF, the interpeak duration more than 40 milliseconds. In case of V1, the negative terminal force or negative part is more than 1 millimeter depth and more than 40 millisecond duration. So this is the Camel hub, is a NOST and then two peaks. The POF abnormality is associated with left atrial dilatation, left atrial hypertrophy, conduction delay, or elevated pressure. This is the 50 years old male smoker. The ECG shows the POF, tall peak POF in the lead 2, 3, and AVF, and also V1. There is also a tall R wave in the V1 and also right axis deviation. This is the typical features of the right atrial enlargement. In case of this is the patient of COPD with pulmonary. The tall peak POF, right ventricular hypertrophy, and right axis deviation. This is the tall peak POF with the lead 2 and the lead V1. This is the right atrial enlargement. This is the ECG showing the POF wide NOST, that means P mitrally, duration more than 120 milliseconds, and interpeak duration more than 40 milliseconds. In case of lead V1, this is totally negative P wave. That means left atrial enlargement. This is the 40 to 24 years old female with a palpitation and shortness of breath had this ECG. In this ECG, there is a right axis deviation, P wave increase in amplitude and duration. In case of V1, P wave is biphasic and positive portion more than 1.5 millimeter duration and negative terminal force more than 1 millimeter depth and more than 40 millisecond duration. There is also a tall R wave in the V1. So this is the ECG of biatrial enlargement and right ventricular hypertrophy. In the case of chronic rheumatic heart disease with mitral stenosis with severe pulmonary hypertension. So this is the biatrial enlargement. ECG features of ventricular enlargement. This is the normal ventricles, right ventricles and left ventricles. In case of ventricular hypertrophy, we search for left ventricular hypertrophy. We search long, tall R wave in the left precordial leads, especially V5 and V6, and look for deep S wave in the right precordial leads in the V1 and V2. In case of right ventricular hypertrophy, thus this is the mirror image, just opposite. We search for tall R wave in the right precordial leads and deep S wave in the left precordial leads. Left ventricular hypertrophy. The ECG criteria for the diagnosis of left ventricular hypertrophy consists of increased QRS amplitude, secondary STT abnormalities, left atrial enlargement, left axis deviation, QRS duration more than 90 milliseconds, and delayed intrinsic deflection. The increased voltage due to increased LV mass, increased LV surface, increased intracavitary blood volume, and closer proximity of the LV to the chest wall. This is the causes of the how voltage increase in the left ventricular hypertrophy. Factor influencing QRS voltage. Number one is sex, race, body habitus, and technical. Is more than 35 years, the ECG QRS voltage gradually decreased, but less than 35 years, voltage may be high in case of less than 35 years. In case of female genders, QRS voltage is slightly lower than the male. Race, racial variance, the African Americans are the high voltage than the others ethnicity. Body habitus, the obese person causes decreased QRS voltage, and lean thin person, female with mastectomy, the increased voltage. There may be technical error for factor influences the QRS voltage. There are several criteria to determine the left ventricular hypertrophy, but some of them are the first of all Sokoliovian criteria. Here, S wave in the V1 and R wave in V5 or V6 more than 35 millimeter, more than equal to. The Cornell criteria, the R wave in the AVL and S wave in the V3 is more than 28 millimeter for male, and in case of female, it is more than 20 millimeter. Modified Cornell criteria, the R wave length is greater than 12 millimeter. The Talbot criteria, the R wave in AVL more than 60 millimeter. The Coito and Spody criteria, the normally R wave is more than V5 than V6, but in case of reverse, when R wave in V6 is more than the V5, it is highly specific for left ventricular hypertrophy. The Framingham score and Romhill stress point score system. The Romhill stress point score system for LVs, there are 13 points. The 5 more than or equal to 5 points is suggestive for left ventricular hypertrophy. The 3 points for voltage criteria, 3 points for ST depression, T wave inversion in patient without digoxin. In patient with digoxin, it only 1 point. The left atrial enlargement 3 points, left axis deviation 2 points, and the QRS duration more than 90 milliseconds, and intrinsic deflection is more than 50 seconds. So total 13 points. In case of voltage criteria, the largest R wave or S wave any limb leads carries 3 points. S wave in V1, V2 more than 30 millimeter. R wave in V5 or V6 more than 30 millimeter. each carry 3 points and total number 3 points. The Framingham score is there is must present of STT changes, secondary changes or repolarization changes, plus any one of them. The R wave in lead 1 and S wave in lead 3 more than equal to 25 millimeter. S wave in V1, V2 plus R wave in V5, V6, that means Sokolov-Lyon criteria more than 35 millimeter. S wave in V1 or V2 more than 25 millimeter. R wave in V5 or V6 more than 25 millimeter. So this is the Sokolov-Lyon criteria. The highest any of the point of the V5 and V6 plus S wave in the V1 more than equal to 35 millimeter indicates left ventricular hypertrophy. The Cornell criteria, the R wave height in the AVL and S wave in the lead 3 more than 28 millimeter in case of male and female more than 20 millimeter. There is several criteria. The sensitivity is very low, but specificity is very high. In case of R wave in lead 1 and S wave in lead 2 or 3 more than 25 millimeter, this is the criteria. R wave in the AVL more than 11 millimeter. The Sokolov-Lyon criteria carries sensitivity 22% and specificity about 100%. The R wave in the only R wave in the V5 or V6 more than 26 millimeter, it's a 98% specific. The Cornell criteria 96% specific. The Romfeld test score in case of 5 points, the 95 about 95% specificity, but sensitivity 35%. So left ventricular hypertrophy occurs in two types: left ventricular volume overload and left ventricular pressure overload. The left ventricular volume overload indicates very tall R wave, ST segment near the baseline or maybe slightly upward concavity elevation and symmetrical T wave upright, and there may be narrow Q wave. This is the findings of left ventricular volume overload. In case of left ventricular systolic overload, there is a J point depression, ST segment depression downwards and convexity upwards, and there is asymmetrical T wave. There is asymmetrical T wave. In case of volume overload, there is symmetrical upright T wave. This is the hypertensive male patient. Here the Sokolov-Lyon criteria: tall R in V5 and V6, and SOF in the V1 more than 35 millimeter. In case of AVL, ROF more than 11 millimeter. In case of ROF in the lead 1 and SOF in the lead 3 more than 25 millimeter. The Cornell criteria, the ROF in AVL more than 11 millimeter and SOF in the lead 3 more than 28 millimeter. So this is the ECG with secondary STT changes with asymmetrical T wave inversion. So this is the hypertensive patient. This is the pressure overload features due to hypertension. This is the another ECG patient presented with SYNCO. There is a left ventricular hypertrophy with stain pattern. This is the ECG of aortic stenosis patient. All criteria, Sokolov-Lyon criteria fulfilled. AVL more than 11 millimeter, and there is also left atrial enlargement and also left axis deviation. So this is the ECG of left ventricular hypertrophy with stain pattern. This is the left ventricular hypertrophy, tall R wave, ST segment near baseline, and symmetrical upright T wave and narrow Q wave. This is the left ventricular hypertrophy with volume overload. This is the another example of left ventricular hypertrophy with volume overload. Here is the left atrial enlargement also. This is a patient with repeated palpitation and family history of sudden cardiac death. Here is the tall R wave in the lateral pictorial reeds, ST depression, and asymmetrical T wave. This is the ECG from hypertrophic cardiomyopathy, apical hypertrophic cardiomyopathy. This is the patient with tall voltage criteria fulfilled, but there is a short PR interval and delta wave. This is the ECG of WPW syndrome. but patient's echo shows the concentric hypertrophy of the LV. He also having concentric variety of hypertrophic cardiomyopathy. So this is another pitfall of the diagnosis of the left ventricular hypertrophy in presence of WPW syndrome.
Sir,
This is the
yep.
ECG of atrial fibrillation. This is the left ventricular hypertrophy. And there is a thumb impression, thumb segment, and a reverse tick sign of the ST segment. So this is the ECG of a patient with mitral stenosis with severe mitral regurgitation with atrial fibrillation. So this is another cause of left ventricular hypertrophy, may be present with atrial fibrillation. ECG diagnosis of LVAs in presence of left bundle branch block. In patient with LVB, there is a difficulties to diagnose left ventricular hypertrophy, specificity low and maybe inaccurate. But there is some features suggestive of left ventricular hypertrophy in presence of LVB. In that case, may be present left atrial enlargement, but the QRS duration is very important. If the QRS duration more than 150 millisecond or more than 160 millisecond, plus any one of the voltage criteria suggestive of left ventricular hypertrophy in presence of LVB, such as this is another study in the S wave in V2 and R wave in V6 is greater than more than 45 millimeter is diagnostic. But another Sokololion index more than 35, R wave in AVL more than 11 millimeter, and combination of the S wave in V2 and V3 more than 55 millimeter, 30 millimeter and 20 millimeter. So this is the ECG of left bundle branch block. There is a very deep S wave, and combination of the S wave in V2 and R wave in the V6 more than 45 millimeter, and QRS duration is prolonged. This is the ECG of LBB with hypertension, left ventricular hypertrophy. ECG diagnosis of LVAs in the presence of RBB. In right bundle branch block, LVAs is suggested by left atrial enlargement pattern, secondary STT changes, and there is a S wave in lead 3 and maximum RS R plus S in any precordial leads more than 35 millimeter is suggestive of left ventricular hypertrophy in presence of right bundle branch block. This is the incomplete right bundle branch block. This is the here no S wave in the lead 3, but some of the precordial leads RS more than 35. Goldberg's electrocardiography tried for dilated cardiomyopathy. That is the S wave in V1 or V2 plus R wave in V5 or V6 more than 35 millimeter. Total QRS amplitude in each limb is less than 8 millimeter, and RS ratio less than 1 in case of lead 4, V4. This is the Goldberg criteria. The in precordial leads, total height of the QRS less than 8 millimeter, and RS ratio in lead 4 less than 1, and the combination of the two is more than 45 Sokololian criteria. So this is the ECG features of the dilated cardiomyopathy. Another frequently asked question in examination: difference between the left ventricular hypertrophy and ischemia. In case of ischemia, there is usually horizontal ST depression and symmetrical T wave inversion. And ECG ST segment elevation occur during STMI, and the STT changes are dynamic. But in case of left ventricular hypertrophy, the ST segment downwards, convexity upwards, there is asymmetrical T wave, and there may be ST segment elevation in lead V1 to V3, and the STT segment are usually static. There is a difference between the ischemia and left ventricular hypertrophy. Pitfalls in diagnosis of the left ventricular hypertrophy. The condition which increases the left ventricular voltage, which interferes with the diagnosis. that is age less than 35 years, in association with WP-Darden syndrome or left axis deviation or radial variation. Some condition which causes QRS voltage may be decreased, such as myxedema, pericardial effusion, cor pulmonale, large anterior MI, এবং heart muscle disease like dilated cardiomyopathy, amyloidosis, scleroderma. These are the pitfalls of the diagnosis of left ventricular hypertrophy in these conditions. Right ventricular hypertrophy. The diagnostic criteria, right axis deviation is the clue. The dominant R wave in the lead V1 more than 7 millimeter or RS ratio more than 1. Dominant S wave in V5 or V6 more than 7 millimeter or RS ratio less than 1. And duration of the QRS less than 120 milliseconds. Supporting criteria, right atrial enlargement, secondary right ventricular stent pattern, and deep S wave in the lateral leads. They may be associated with right bundle branch block. There is a right ventricular hypertrophy. First clue, the axis deviation. There is a right axis deviation. The R wave height and S wave amplitude and QRS duration must be less than 120 milliseconds. This is the diagnostic criteria of right ventricular hypertrophy. Right ventricular hypertrophy, again, two types: right ventricular hypertrophy with pressure overload and right ventricular hypertrophy with volume overload. In case of right ventricular hypertrophy with pressure overload, the tall R wave, ST depression, and asymmetrical T wave inversion. But in case of right ventricular volume overload, there may be RVB pattern and T wave change does not occur. Diagnosis of right ventricular hypertrophy in presence of right bundle branch block is another difficult situation. But Barker and Valencia criteria is in case of incomplete RBB, if there is R wave height more than 10 millimeter, and in case of complete RBB, if there is R wave height more than 15 millimeter, then suggestive of right ventricular hypertrophy in the presence of RBB, but sensitivity and specificity is lower. The various diagnostic criteria, their sensitivity and specificity. RS ratio in V1 more than 1, the 98% specificity. R wave in V1 more than 7 millimeter is 99% specificity. The opposite, same reverse, is the S wave in the V5, V6 more than 7 millimeter and V5, V6 RS ratio less than 1. This is the 93% specificity. This is an 18 years girl presented with central cyanosis and digital clubbing. Here, right axis deviation present. There is a tall R wave in V1, J point depression, ST depression, and asymmetrical. That means right ventricular hypertrophy with stent pattern. This is the patient from repeated palpitation and syncope. There is a right axis deviation, the first clue. Then the RS ratio in the lead one more than 1. And there is a epsilon wave in the junction. This is the ECG of arrhythmogenic right ventricular dysfunction. Pitfalls in diagnosis of right ventricular hypertrophy. There is some problem in the diagnosis of ECG in the presence of the following, such as right bundle branch block, WPW syndrome, true posterior MI. In case of children, maybe normal voltage may be higher, early transition, dextroposition or dextrocardia. In case of hypertrophic cardiomyopathy, there may be tall R wave and V1 and RS ratio more than 1 may be observed. In case of biventricular hypertrophy, there is any presence of left ventricular hypertrophy plus any sign of the right ventricular hypertrophy, include right axis deviation, right atrial enlargement. There is a biphasic QRS complex in the mid precordial lead, especially V2 to V5. The total combination of the R wave and S wave more than 50. This is called Katz-Waschel phenomena, and deep S wave in the V5 or V6. In case of presence of the RVs, additional signs indicating the left ventricular hypertrophy include the tall R waves and deep S waves in V2 to V5 and QRS amplitude more than 50 millimeter. These are the ECG features of
I
the
think we're missing the sound.
This is the ECG showing a tall R wave in the tall R wave in V1 more than 7 millimeter, RS ratio more than 1. There is a increased QRS voltage in the mid portion more than 50 millimeter total length of the R wave and S wave. This is a Cat-Schwarzschild phenomenon. It is found mostly in the ventricular septal defect and other congenital heart diseases. So summary of the ventricular hypertrophy in right ventricular hypertrophy and left ventricular hypertrophy. So if you found the tall R wave in case of right ventricular hypertrophy in the and secondary STT changes in the lead V1 and V2. And in case of left ventricular hypertrophy, it is the left-sided lead, such as 1 AVL and V5, V6. That's opposite for the S waves. The usually deep S wave in the right ventricular hypertrophy found in the 1 AVL, V5, V6. And in case of left ventricular hypertrophy, it found V1 and V2. In case of right ventricular hypertrophy, there is a right axis deviation. In case of left ventricular hypertrophy, left axis deviation. In case of right ventricular hypertrophy, right atrial enlargement. In case of left ventricular hypertrophy, left atrial enlargement. There may be right ventricular hypertrophy with RVB and left ventricular hypertrophy with LVB present. There is additional criteria for right ventricular hypertrophy. There is poor progression of R waves and there is delayed inter-square duplication. Conclusion, ECG is very specific, but not sensitive for diagnosis of chamber enlargement. But ECG is the cheapest and most readily available. Clinical utility is limited by its low sensitivity. So, thanks to all for patience hearing.
All right, I can make some comments. Actually, very nice overview of ECG criteria for chamber enlargements. One thing I'd like to, just for our students and trainees, to make sure they understand the clinical connection of this chamber enlargement. They need to keep in mind that the chamber enlargement happening for a few reasons, right? One is pressure overload or after stress, while stress is high or afterload is high in certain area, and valvular problem, but they also are connected, okay? So in that situation, this component they have to keep in mind, and the second component they have to keep in mind, what is the axis on the ECG, okay? So if you look at that, I have a heart model here, okay? And as you know, always think about three-dimensional way rather than memorizing it. Because you mentioned, Dr. Kundu mentioned that students are asking, what are the reasons for like left atrial enlargement or left ventricular enlargement, So, but if you keep in mind three-dimensional way, say what are the problem there, what direction the axis is going. If you have left ventricular enlargement, definitely, then you will have the axis is going to go to the left side, right? This left side is presented by 1 AVL, even minus 30 degree to the left shoulder area, and V5, V6. Look at those leads, and if you can look at those leads, focus on those leads, and then you'll see all the criteria depends on that. Like Cornell criteria, they have AVL. A modified Cornell, also AVL. So because those are in the left side. So if you see left axis deviation, you start thinking about, with this, and if you see other criteria there, and then you have to think about what are the causes clinically, right? So as for example, like if you have aortic stenosis and the aortic valve stenosis, what's going to happen? Wall stress is high, and afterload is high. So slowly is going to recruit more muscle by Frank Starling curve wise, and then you'll see, thickening of the heart muscles and to overcome that pressure gradient across the aortic valve, overcome the afterload. So that's the thinking process you need to start developing in your mind, three-dimensional way. As for example, if it's a PDA or VSD, you think about, okay, this volume overload is going to be on the right side first, not on the left side, right side first. then initial enlargement you're going to see on the right side, right ventricle and right atrial enlargement, and subsequently in the later stage you might see coming on the left side. That will be the late stage of the situation. This clinical thought process, and understand that all the valves, they don't have any active mechanism. They're passive, right? It depends on the gradient. So that's why when you put the TAVR valve, you just put it there, leave it there, and it starts working because of the gradient. There's no active process. So I like the students and trainees to think about three-dimensional way, and also look at the axis, and then you can figure out the correlation between the hypertrophy and clinical situation. What are the clinical causes could be. Because if it is like pulmonary stenosis, what's the effect is going to be? Blood cannot flow to the lungs. The pressure on the right ventricle will be higher, right? And that can reflect the right ventricular thickness, and then also can reflect in the long-term right atrial enlargement. So like tetralogy of Fallot, right? Main problem is on the right side. So thickening of the right ventricle is going to happen. So if you think about three-dimensional way and keep in mind, then you don't have to memorize what are the causes of that. So, and this is clinically very important. When you see the ECG, also put in your mind what are the potential causes could be. So, thank you.
Can I make a comment?
Yes.
This clinical connection is so much important in practical life. Let's say you are working in a Upajala center. A patient has come, hypertensive. He's complaining that he has shortness of breath whenever he's carrying weight. Look at his ECG. You find there is only left atrial enlargement, no evidence of left ventricular hypertrophy. But that suggests the patient have elevated left ventricular and diastolic pressure. That's why the left atrium has become bigger. And that suggests the patient is very likely to have LVH. You should remember, ECG is very, very much less sensitive. But the adjunct findings that can help you to reach a conclusion. That means this patient has LV diastolic dysfunction. He's going to have heart failure with preserved ejection fraction. That's the way we should interpret science and every findings of an ECG of chamber enlargement.
Sir, I have a question, Rafiq Ahmed sir. Rafiq Ahmed sir, can I ask you a question? Sir.
Yeah.
Sir, many a times we see the patient with LVH or HCM having the pattern of short PR interval. Can we straightway say it's due to accessory pathway, or it is inherent to HCM?
The question is hypertrophic cardiomyopathy with short wave. It's not always present. It's just where the P wave is coming from. And also two factors. One is the P wave coming from really high up in the sinoatrial node or in the lower part of the sinoatrial node. And that will change the PR interval. Number two, AV conduction can be accelerated. And rarely you can have pathway, nodofascicular pathway to make the PR short. So that's about it. I just reported as a finding without making too many comments. We have to be careful about over-interpreting something. Wadud mentioned something that if you are in a Upajala health complex and you think somebody has LVH, and you can make an assumption, maybe there is diastolic dysfunction. I mean, this is the good old clinical medicine that our professors used to practice. They didn't have anything at all, no investigation, nothing. But we at least have the EKG available. But then you have to be careful also that same patient can have a dilated cardiomyopathy. That
Yes.
was so you can make some idea about it. But then if it is somebody has heaving apical heartbeat, really, and then LVA, then you know it's probably not dilated. So that's why the clinical medicine comes in. But be careful about over-interpreting ECG and getting too much out of it. Thank you.
Sir, assalamu alaikum. Can I make some comments, sir?
Sure, please do.
So ventricular enlargement and hypertrophy gives us the assessment of the ventricular which chamber involved. But as well in congenital heart disease, we have some clues with axis and clockwise and counterclockwise loop. Means if a case in a ASD, we get RBB with normal axis, right axis, or left axis. So if we get normal axis with RBB, then it gives us the clue of it is a second ASD second dam. If there is left axis with RBB, it is ASD primum. And if we get RV hypertrophy along with RBB in ASD, that is also give a clue us that operable case of ASD present or not. If there is monophasic RVH, means QR pattern with strain pattern, it gives us that ASD with having severe pulmonary hypertension and the axis going towards right axis. It also gives us clue that this patient is becoming inoperable. Like in VSD also, axis is very important in diagnosis, in hemodynamic significance, and the type of VSD. Like in VSD, usually we get left-sided chamber enlargement along with normal axis. But if we get left axis, then it gives us a clue that it is inlet extension of VSD. Because we know that inlet VSD and ASD primum, there is endocardial cushion defect, and there may involvement of the AB conduction tissue maldevelopment. So the axis in ASD primum, AB canal defect, and inlet VSD, the axis will be left axis. In also here in VSD, that Wadhu sir mentioned, in a cardiologist or pediatrician, history is very important. If patient having no symptom, previously having respiratory tract infection, and now having no infection, now respiratory resolved, then it gives us a clue that the pulmonary pressure becoming irreversible. And ECG also gives us a good clue that Samir sir has explained, that cat-Wachtel phenomenon that is present in tall V3, V5, V4 has tall R and deep S, more than 50. And along with this axis, we are getting right axis, that it is suggestive of that this patient is giving on Eisenmenger syndrome. But cat-Wachtel phenomenon with biventricular forces with normal axis, this patient still having symptom gives a clue that it is a operable case, and we will send the surgeon for early intervention. And another thing is clockwise and counterclockwise loop. In clockwise loop, usually in normal person, and most of the congenital heart disease has clockwise loop evident by Q wave in lead 2, 3, AVL. And counterclockwise loop, Q in lead 1 and AVL, that gives us that it is a case of left axis involvement, means inlet VSD or ASD primum, or some other complex congenital heart disease like single ventricle, DORV, this type of. So axis, RVH, LVH, clockwise, counterclockwise, and history along with ECG findings, we can help the patient to reach the diagnosis and give a early intervention is needed or not, sir.
Thank you. I just want to make a quick comment on this. So for the audience, look, what Naruma actually described very fluently, and we have a group of people here. Each of us are expert in our own field. So as a collective, we have a significant amount of knowledge. But what Naruma just said, I could not have said all those things, even though I know EKG very well. And that's the humility of ECG. So what I would like the audience to do, but remember the point. So if you see something funny, open the book. I still do it. And today you don't background.
Ripu,
Okay.
please silent.
Okay. So what?
Kamrul, make silent, please.
অন্যদেরকে মিউট করে দেন প্লিজ।
So it is so important that we cannot store a huge amount of information in our brain, but we can store part of it, and then we can.
Kamrul, please background বন্ধ করেন।
রিভুকে মিউট করেন। রিভুকে মিউট করেন। কেউ নাই অ্যাডমিন?
Okay, so the point I was trying to make is that the point I was trying to make is that we have to be, we need. Okay. The point I was trying to make that we must keep the habit of opening the book. And today, actually, we don't have to open the book. You can Google it. Mr. Google is amazing amount of information that is online available. So you can, when you find a funny ECG, just take a few minutes. So what I tell people that spend a little time. Just don't cursorily look at an ECG. Give it a 1 or 2 minute time. And if you keep doing it over and over again, you will get it. And you will then remember it. Then again, after a few months, you will forget it again. I forget it. And then I remind myself again. I keep doing it again and again. And I have been doing it for the last 40 years. So please do that. Thank you.
I'd like to make one comment here that it's very important to get some idea from the ECG, but their specificity and sensitivity is not that great with all the understanding that we have. So in order to, like, particularly in congenital heart disease, in order to define whether the patient is a surgical candidate or not, I believe those sort of situation, right heart catheterization is important. We really need to definitely know what's the pulmonary pressure, whether it is way up more than 2/3 or not. That's a criteria to and definitely some other criteria. There are surgical criteria, well-developed criteria and guidelines there. So yes, ECG will give us some idea, but depending on that solely, I'll not send for surgery. Probably I'll get a right heart catheterization first, and definitely they need to have surgical consultation. But in the process, we need to have better understanding of the right pulmonary pressure on those type of patient. Thank you.
Hafiz bhai চুপ কেন?
Assalamu alaikum, sir. So we can move to. Assalamu alaikum, sir.
Sudhir, do you want to make some question or comment?
Sir, yes, sir.
Please.
Sir,
please
my
proceed.
first question is, do we still use the term left atrial enlargement and the right atrial enlargement? So we know that even without enlargement of the atria, we can have the ECG abnormalities due to any diseases. If there is a scarring in the atria, or there is deposition disease or something else. So I think the term has to be changed. In some textbooks, it is recommending that left atrial abnormality and the right atrial abnormality has to be used instead of enlargement and dilatation. And it is also said that in extreme right atrial enlargement, the ECG may mimic left atrial enlargement.
Yes.
So what is the mechanism of that? And when we have extreme left atrial enlargement, the P-wave amplitude may increase, and it may again mimic that of right atrial abnormality. So what is the mechanism? And why in left atrial enlargement, we have the increase in the duration of the P-wave, but this is not the case in case of the right atrial enlargement. Why we get the increased amplitude in case of the right atrial enlargement? So these are my few questions.
Right, I can
Samir,
answer.
no, let the speaker do this.
Okay.
Samir, questions for you.
Samir, can you unmute? Yeah.
There is a left atrial, he is absolutely right, says that the term with the left atrial enlargement may be changed to abnormalities. But in case of left atrial enlargement, it is due to left atrial hypertrophy, left atrial enlargement or scarring, or there is a conduction abnormalities. So in case of, it may be mimic, there is a left atrial enlargement may looks like may be associated with increased height of the P wave usually. So that's all.
Can I make some comment? Look at the heart. The right atrium, left atrium, they're overlapping. In the just right atrium is in front of the left atrium. The SA node in the right atrium. If it is enlarged or hypertrophied, the time to travel the whole of the right atrium, it takes a little bit, it doesn't take much time. So within the normal time period that takes to depolarize the left atrium, right atrium is already depolarized. Only the amplitude will be increased because of the increased muscle mass. But what about left atrium? If it is enlarged, the time for the impulse to conduct from the SA node, which is at the right end of the right atrium, to the end of the left atrium, it will be longer. And that's why there's increase in the duration. That's the point. And I also remember, whenever there is huge right atrial enlargement, look, when we record the ECG, the V1 or V2 leads, they are placed in a fixed position. But in the heart is enlarged, the atrium enlarges downwards. The whole force of the current is actually, main force of the current is going down. That's why sometimes right atrial enlargement presents with current going down, negative amplitude in the V1. And that mimics left atrial enlargement.
So one comment about the terminology. So let's say there is a septal MI by ECG. The reason it happened is somebody put the leads high up in lead intercostal space. So by ECG, we report it as a septal MI. That doesn't mean that the patient has septal MI. That's where the sensitivity and specificity of the test come in. Same with left atrial enlargement. When we find that there is left atrial, of course, there is a degree of sensitivity and specificity that we need to look at. Now, on the other hand, if we keep talking about left atrial abnormality, then ECG, we're going to report ECG at the end, abnormal ECG, without describing any finding at all. So that's where the problem comes in. And I agree totally that some of the cases where ECG will report as left atrial abnormal enlargement, actually, there is no enlargement. And the only way you can find it is by echo. And I think this will be true for left ventricular hypertrophy also, that there will be a number of patients who will have ECG finding of left ventricular hypertrophy. If you do echo and do muscle mass, there will be not. And that's, again, it comes to the point of sensitivity and specificity of a test. Thank you.
So, Adut bhai?
Hafiz bhai কি কমেন্ট করবেন বা দেখাবেন কিছু?
Hafiz,
What's that?
Hafiz এর ECG আছে কিছু আজকে?
আমি জানি না সময় আছে কিনা।
সময় আছে।
আচ্ছা,
অনেকদিন পরে পাওয়া
I just wanted to make one comment because I think ECG is a tool and a key to clinical diagnosis. So don't get too much emotional about diagnosing everything through one EKG. And on the other hand, the key is to recognize the EKG abnormality and use that as a key to other investigations and other evaluation. I think sometimes we get bogged down with that as well. So, for example, in a young patient in a remote area with some LVH, and the patient is lean, thin, you don't give a diagnosis, and then the family will be devastated with that diagnosis that heart is enlarged. So I think we have a responsibility too. And I think in a resource constrained area, it is even more important to know this better so that we don't cause unnecessary anxiety for this kind of thing, you know.